All right, well, everybody, so we're going to continue on with the cardiovascular system, looking at chapter 20, and this chapter focuses mostly on the heart. So remember, if you'll recall, the cardiovascular system equals the blood, which is talked about in chapter 19, the heart, which is chapter 20, and the blood vessels, which is chapter 21. So what is the heart? The heart is the center of the cardiovascular system. It weighs about 350 grams. It's about the size of your closed fist, okay? Like we saw earlier with the brain is almost like both fists put together as the size. The heart is about the size of your closed fist. It beats more than 10,000 times per day. The pump that circulates blood through an estimated 75,000 miles of blood vessels. So if we took all your blood vessels and we put them end to end, they would range over 75,000 miles. So this pump has to be able to pump blood over a great distance. Cardiology is the study of the normal heart and diseases of the heart, and this is why if somebody says they're going to a cardiologist, it's going to be focusing mostly on that individual's heart. So where is the heart located? It is located in what we call the mediastinum. Okay, the media means towards the middle. Sternum is behind the sternum here, so it's right in kind of the middle of the chest. It lies immediately between your two lungs. So your two lungs sandwich around your heart and the pleural membranes that cover those lungs. The base of the heart is tipped up medially and posteriorly, and so you can see it's kind of like it's an upside down triangle, while the apex, which is more the point, projects inferiorly and laterally. Okay, so down and to the side. So if this is my hand, kind of like a triangle, it's looking more like this, okay, to the side like that. All right, right here on the left side of your chest, it's more towards the left. Now, one thing to note is when we looked back at chapter 4 and you looked at tissues, you learned about membranes, and we talked about some membranes like the peritoneum, the pericardium, and the pleura. So here we're going to talk about the pericardium. The pericardium is a sac that surrounds the heart. It helps hold the heart in place. It is made out of an outer fibrous pericardium. This is tough, dense, irregular connective tissue. There's an inner serous pericardium. This is the parietal layer, or the outer layer, plus the visceral layer, which is the layer up against the organ itself. A lot of times, since it's up against the heart itself, it's also called the epicardium, which we'll talk more about in a minute. The space between those two membranes is called the pericardial cavity, and there's going to be fluid in that space. Again, the fluid is there for lubrication, because as the heart pumps and beats, there's going to be movement, so we don't want those layers to be going back and forth like this. When you do this, it creates friction, which releases heat. We don't want that to happen. So the fluid is in there to allow for it to move more smoothly, okay, when we talk about that pericardial cavity. Now, if something happens to this membrane and you get what we call pericarditis, this is inflammation of the pericardium. It can be very painful. You're going to get either painful friction between the two membranes because of the back and forth, or you actually get too much fluid in there. Okay, the space is only so big, and so too much fluid gets in there, which then starts compressing on the heart itself. Okay, when it compresses on the heart and it starts smashing the heart, this is called cardiac tamponade. All right, so when we look at the heart here, you can see that it fits into the pericardial cavity. It moves into the cavity. One way that you can kind of do this, if you take a large Ziploc bag, like the gallon size, and you put some water in it and then tighten it, okay? If you put your fist up into it, it will actually consume and come around your fist. That's how the pericardial cavity works. It has the layer that'll be touching your fist, the layer outside, and the fluid in between, and that kind of mimics the pericardial cavity. You can also see here in the picture, it's showing you the layers of the pericardium as they relate to the heart. All right, so this is just some illustrations of how the pericardial cavity and the membrane works. So now let's talk about the wall of the heart itself. So we see here we have first the epicardium. This is the visceral layer of the pericardium, so it's going to be the outermost layer of the heart. When we look at this, it's made of mesothelium plus some connective tissue, and this is just the typical tissues that make up a serous membrane, since this is the visceral part of the pericardium. We then see the second layer, which is the myocardium. So anytime we see myo on there, we're talking about muscle. So this is the cardiac muscle. This muscle is involuntary. Okay, you don't have conscious control over it. It also is striated. It does have those sarcomere structures that you learned back in the muscle chapter, which makes them look striped. However, they're also branched. The reason they're branched is that we want all of these muscle fibers in the heart to be able to communicate very easily, and these branches allow for this so that they all contract together. All right, we don't want part of your heart contracting at one point and part at another point. We want all of them to be contracting together to push blood the most in the most efficient way. There are two separate networks of these muscle fibers. There's what we call the atrial fibers. These are going to be the two top chambers of the heart. And you have the ventricular fibers, which are going to make up the two bottom layers of your heart. Between these branches, you're going to notice that there's going to be areas that are called intercalated discs. These are going to be thick cross walls of the sarcolemma. Remember, sarcolemma is the plasma membrane of a muscle cell. These are going to have gap junctions in them. And if you recall, gap junctions are little holes that allow them to be able to share cytoplasm, but this also means that they are able to communicate with each other very quickly. Okay, they don't have to leave the cell and then go back into another cell. They can just go through these little holes or these gaps that are located here. This allows those action potentials to spread very quickly so that when we're ready to contract the atria, they all contract at once. And then when we're ready to contract the ventricles, the bottom part of the heart, they all can contract at once. All right, so the structure is very, very important for its function. The third layer here is called the endocardium. The endocardium is the innermost layer of the heart. Endo means inside, so it's the innermost layer. This is a very thin layer of connective tissue, and the endothelium is going to have a similar structure to our blood vessels. And when we get to the blood vessels chapter, you'll kind of see the similarities that are there on that innermost lining of the heart. So now let's talk about the chambers of the heart, because we talked about how there's two different networks of fibers in that myocardium. There's the atrial fibers and the ventricular fibers. So let's look at these chambers. The first two chambers we want to look at are the upper chambers, and these are called the atria, or also known as the right atrium and the left atrium. And I'm going to abbreviate these a lot of times in these notes. So when it says RA here, that's the right atrium. If it says LA, that's the left atrium. These are going to be separated by what we call the intra-atrial septum. So it's going to have an area that separates the two chambers. Intra is in between, atrials, talking about the atrium. The atrial walls, guys, are very thin. It doesn't have a very thick muscle, and this is because that they don't have to push the blood very far. What they're going to be doing is they're going to be contracting, and they're going to be pushing the blood down to the two lower chambers of the heart. So they don't, of course, it's not traveling very far for one, but they also have gravity to help them in this process of the blood moving down. Now, each atrium does have a very special structure called an auricle. This auricle is a pouch-like extension. It actually kind of looks like a little dog ear on the side, and this is going to help with increased volume. As more blood comes into that, it allows it to have more space to expand. Okay, it's almost like having where you may have planned an area where your party's going to be, but when more people come, you have another area that it can expand to that's connected to it, so there's an overflow that can happen. This is the same thing that we'll see with the atria. They have this ability to be able to take in more blood and put it into that overflow area if needed. Now, on the other hand, we'll see that we have the two lower ventricles. We have the right ventricle, which we have abbreviated as RV, and we have the left ventricle, which is abbreviated as LV. These guys are separated by the intraventricular septum. So again, they're separated here by a divide or septum, which is going to separate the right side from the left side. Now, if you'll notice in this picture, you'll see that the ventricular walls are a lot thicker than the atrial walls are. And the reason is they have to pump the blood a lot further. Therefore, they're going to need a lot stronger muscles in this area to do this. Now, the right ventricle over here is going to pump blood into the pulmonary circulation. So it's actually going to pump blood to your lungs. They're going to pump blood to the lungs so they can pick up oxygen. This is why you'll also see in this picture that all the blood on the right side of the heart looks blue, because it's low in oxygen, right? It hasn't gone to the lungs yet and dropped the carbon dioxide off and picked up the oxygen. Therefore, we normally represent that as low oxygenated blood as blue. When we see this, though, this is pretty low pressure because the heart is sandwiched between the lungs, and so we're going to push the blood up and to each side, but again, it's not a very great distance. Okay, they're not pushing it very far. On the other hand, the left ventricle pumps blood to our systemic circulation. Our systemic circulation is every other tissue in our body. Okay, it's going to send blood that's oxygen rich. That's why you see it in red over here. Oxygen rich blood that just came back from the lungs, and and it's going to send it out to the entire body. So because of this area is going to have a lot of high pressure in it, and this is why we take our blood pressure from this area, okay, for the high pressure. And you'll notice that the wall of the left ventricle is a lot thicker. It's actually 2 to 4 times thicker than the right ventricle wall. So this is going to show you had the 2 top chambers, which are called the atria. You have the 2 bottom chambers, which are called the ventricles. Now, there are going to be some special structures that are located in between these different chambers, okay? If you think about it, like in a castle, when they used to talk about the chamber, it's like their room. And there's always a door to that chamber, all right? We have that closes it off. Well, these chambers have to be separated, okay? They're like little rooms, and they also are going to have doors, though, to allow for blood to flow. And so these doors inside of your heart are called valves, okay? So we're going to talk about the valves of the heart. The valves are made of dense connective tissue. They are covered by an endothelium. The valves, the whole point is to prevent backflow of blood into the heart. So this allows for blood to flow in one direction. So when we're looking at the atria is going to contract and push the blood down into the ventricle. Once the blood gets in the ventricle and it's going to contract to go, say, to the lungs, we don't want it to backflow back up into the atria. We don't want that to happen. So the door gets shut, and so when the ventricle contracts, the blood can't go back the direction it had come. It's going to be shunted towards the lungs. All right, so these valves act like doors to allow for one-way transport of blood. Now, there's 2 main kind of categories of these valves. The first are called the atrioventricular valves, or the AV valves. These are the valves that are going to be between the atrium and the ventricle. So we have one between the right atria and the right ventricle. This is called the tricuspid valve. The reason it's called the tricuspid valve is it has 3 flaps to it, or what we call cusps. So tri means 3, and so this lets you know about its name. On the other side of the heart, between the left atria and the left ventricle, we have what we call the bicuspid valve. Bi means 2, so these have 2 cusps or flaps. A lot of times, though, the bicuspid valve is also known as the mitral valve. So you should know that bicuspid valve and mitral valve are actually the same thing. Now, these valves have some very special structures that help hold them closed or open them up depending on what needs to happen with the movement of blood. They have this area that's called the chordae tendineae. These are tiny tendons that are going to keep the flaps of these valves pointing in the direction of the blood flow. So this allows for when the blood's supposed to move from the atrium to the ventricles, it's going to allow them to point the valves down, so that way the blood can flow the way it's supposed to. However, these tendons are connected to muscles. The muscles they're connected to are called the papillary muscles. These papillary muscles will pull, okay, on the chordae tendineae. So when they pull, when they pull on those tendons, it causes almost like a parachute type effect, okay? Because the flaps were pointed down like this, but when the tendons get pulled, the flaps move up and close. This doesn't allow the blood to move up into this area, so that way when the ventricles contract, it pushes the blood towards either the pulmonary circulation or the systemic circulation. When the ventricle is empty and we need to refill it with blood, those muscles will relax, and we see that the parachute type structure will invert and come back down so that the blood can then drain back in there. So these muscles in these chordae tendineae help open and close these valves. All right, so if you take a look here, this shows you a picture of how the valves look. They're showing you the bicuspid valve because it's just showing you that it has the 2 cusps. When they're open, you'll notice that the valves are pointing down, okay, and so blood can flow down. You can see the chordae tendineae here, which are they're slack or they're loose with the relaxed muscles. But when the muscles contract, it pulls these tendons tight, and it pulls the tendons tight. It kind of makes that parachute type structure, closing that valve so the blood cannot go back up into the atria that it just came from. Okay, and so that's what you're going to be looking at. And so when you do your heart dissection, guys, these are some structures you can definitely see between the atria and the ventricles on each side of the heart. So pay attention looking for these chordae tendineae and these papillary muscles. On the other hand, the other set of valves are going to be the valves that are going to prevent backflow once the blood leaves the heart, whether it leaves through the right ventricle and it goes into the pulmonary circulation, or it leaves through the left ventricle and goes into the systemic circulation. So these valves are called semilunar valves. When we look at pulmonary semilunar valves, this is going to be between the right ventricle and the pulmonary trunk, which leads to the lungs. The aortic semilunar valve is going to be between the left ventricle and the aorta itself. And this shows you a picture of what these semilunar valves look like. Now, these valves are made of 3 crescent-shaped cusps, and they attach to the walls of the artery, whether it's the pulmonary artery leading to the lungs or the aorta, which is the main artery leaving the left side of the heart. When the ventricles relax, these cusps fill with blood and they close together. This is to prevent the blood from flowing back into the ventricles. Okay, so they push the blood forward, but as the ventricles start their process of relaxing, these guys are going to close, and so that the blood can't come back in that opposite direction, because guys, in this case, we are pushing blood up. Well, gravity wants to allow it to come back down. These valves help prevent that from happening. Now, one thing I want to kind of talk to you about that deals with valves as a type of sickness is rheumatic fever. Rheumatic fever can actually cause some issues with the heart. It's normally due to complications of a group A strep infection, and it can lead to damage to the heart valves. But more specifically, for whatever reason, it especially affects the bicuspid valve, which we also call the mitral valve, and the aortic semilunar valve. Both of these are the valves on the left side of the heart. So for whatever reason, we see that those valves are affected more in rheumatic fever than the right side. What happens here is that the bacteria attaches to these valves, and then our antibodies who are fighting the bacteria, they actually don't just attack the bacteria, they also start attacking the valve and tissue itself. It's not the only place this happens, though. It can also attack our joints and even other tissues if the bacteria is present and spread to other areas. And when you normally, guys, think about strep, you're thinking strep throat, which starts here in the throat, and that's true, but it can spread to other areas. So if we're looking here at the heart valves and their circulation, when one set of valves is open, the other set is going to be closed. So in the first picture here, you're going to see that the valves between the atria, because the atria have been cut off here, so you can't really see them, they've cut them off, but they're going to see that the valves from the atria to the ventricles are open in this first picture. However, the semilunar valves are closed. When the semilunar valves are opened, the AV or atrioventricular valves, the tricuspid and bicuspid valves, are closed. So this is showing you that there's kind of going to be this back and forth pumping motion. So when the atria contract, it's going to push blood down here, okay? And then when they relax, these guys are going to contract and they're going to push blood out into the system. And so it's going to constantly go back and forth with these doors or valves opening back and forth as the heart pumps the blood. Okay, so this is kind of what your heart's actually doing when it's pumping the blood. So let's do an overview of blood flow, okay? It should be very important that by the time you're done with this chapter, you can actually trace blood from a specific area, okay? Doesn't matter where I give you in this kind of flow chart area, you should be able to take it from there and get it all the way back to where you started. Okay, that's really something that's important with blood flow. So we're going to first start with the systemic circulation. The systemic circulation is the blood vessels which supply the body tissues with oxygenated blood. Okay, and so this is going to be where the blood's going to leave the left side of the heart through the left ventricle, that's the LV, and it's going to return the blood to the right side of the heart, which is the right atria. So when we look at this, the left ventricle is going to contract and push the blood through the aortic semilunar valve. Those semilunar valves will open so that the blood can enter the aorta. So you can kind of see the flow chart here. The aorta plus its smaller arterial branches, which we call arterioles, are going to distribute the blood to the rest of the body. They eventually are going to get into smaller vessels that we call capillaries, and then they're going to go into venules, which just become veins. Veins are going to return the blood to the heart. Now, more specifically, the main vein that returns blood to the heart is known as the vena cava. Now, the cardiac cycle we're talking about here is the flow of blood inside the chambers of the right side of the heart. So now we have the blood in the vena cava, and it's now going to enter into the right atria. So when we look at this, it's systemic circulation, which we just looked at. It's going to enter the right atria, then it's going to go to the right ventricle, and then it's going to enter pulmonary circulation. Now, the right atria is going to receive blood from the body tissues via the inferior vena cava, the IVC. And inferior vena cava means it's going to bring the blood up from the lower part of your body, okay, below the diaphragm. The superior vena cava is going to return the blood from your upper body, like your arms and your head, to the heart. We also see the heart itself needs its own blood supply, and it needs to return the deoxygenated blood back here as well, and that's going to be returned through the coronary sinus. So all the superior vena cava is going to come in, the inferior vena cava is going to come in, and off the heart itself, the coronary sinus, and they're going to return the blood from the rest of the body, the systemic circulation, back to the right atria of the heart. This blood is now deoxygenated. Okay, oxygen has been dropped off, and it contains a lot of carbon dioxide that needs to be taken to our lungs and released as waste. The superior vena cava again brings blood from the upper body, which is above the heart. The inferior brings blood from below, or the lower body. The coronary sinus brings blood from the heart muscle itself. When we want to move from the right atria to the right ventricle, the tricuspid valve must open and blood moves down into the right ventricle. So blood leaves the right atria and enters the right ventricle. Then, once we see it's in the right ventricle, we're going to have the ventricle contract. The pulmonary semilunar valve is going to open, and the blood enters into the pulmonary circulation. Right? So this is what we would call the cardiac cycle, where we actually see the blood moving through the right side of the heart here into the pulmonary circulation. Now, with pulmonary circulation, the blood vessels which carry deoxygenated blood from the right ventricle are going to take this blood to the alveoli of the lungs. Once they get to the lungs, it's going to allow for the gas exchange to take place, dropping off the carbon dioxide and picking up the oxygen you just breathed in. Okay? This is going to then allow the blood to move from that right side of the heart, the right ventricle, through this pulmonary circulation to the left atria, to the left side of the heart. So we see the right ventricle is going to push the blood through the pulmonary semilunar valve as it opens. The blood is going to enter the pulmonary trunk. The pulmonary trunk then is going to branch into two pulmonary arteries, because you have two lungs, so it's going to branch to the right and the left to go to each lung. It's then going to enter the capillaries in the lungs, where again the blood's going to pick up the oxygen and it's going to drop off the carbon dioxide, and it's going to do these at these special structures in the lungs called the alveoli. Then it's going to enter the pulmonary veins, which are going to take the blood back to the heart, and more specifically the left atria of the heart. Now we're entering back into the heart, so now we're looking back at another cardiac cycle, the flow of blood inside the chambers of the left side of the heart. So pulmonary circulation is going to send blood back to the left atria, which then is going to enter into the left ventricle and then eventually return back to the systemic circulation. So the left atria receives blood from the pulmonary veins. The bicuspid valve opens, allowing blood to move into the left ventricle. Once it enters into the left ventricle and the ventricle contracts, the aortic semilunar valves are going to open, and the blood is going to be pushed into the aorta, and it's going to enter back into systemic circulation, which is where we started this process. All right, so this is a really big deal to see how the blood is going to move through the two circles of circulation, whether it's pulmonary with the lungs or systemic through the body, but how the heart connects both of those circulations. Now, in your lab book, there's a really good flow chart kind of diagram for you to take a look at on page 438 in your lab book. It goes through and it starts you with the right atrium, and it wants you to trace the blood from the right atrium all the way back to the right atrium. It also has a picture on page 439 to help you out as well. This is a really good study tool because it is important to be able to trace a drop of blood from somewhere within the heart back to that same area. So in your textbook, you also have a really good example, and it shows you in two different ways how the blood flows through these areas of the systemic and pulmonary circulation. This is found on page 699 in your book. So if you look over here in the If you look on the left side of your screen, you'll see that it's in the picture form. It's showing you where blood starts with number 1 in that right atria and how it travels through. And in words over here, you can see that they correspond with the structures, okay, in the same way, but it's more in a flow chart. These are 2 different ways to help you be able to study how blood flows through the heart and the systemic and pulmonary circulation. So, not only do we have to get blood to the entire body itself with its tissues, we also need to be able to supply blood to the heart itself. This has its own special name, and this is called coronary or cardiac circulation. The heart itself requires nutrients, oxygen, and it needs its waste removed just like any other tissue in the body. This is so that it continues to work properly. So when we look at this, you have a right and left coronary arteries that are going to branch off into smaller arteries, and they are going to branch off of the ascending aorta. So once all the blood goes into the aorta from the left side of the heart, we're going to see that the aorta will branch off and it will supply to the coronary circulation as well as continuing through the rest of the body with the systemic circulation. The whole point here is to carry oxygenated blood to the myocardium, to the actual heart muscles, so that they can continue to do their contractions. Muscles need a constant supply of energy, and remember, energy is going to be gotten through cellular respiration. Cellular respiration requires oxygen and glucose, and this is to make that ATP. So we need our heart to have a constant supply of nutrients and oxygen in order to continue to make ATP so that your heart does not stop beating. Deoxygenated blood then needs to be removed. We need to get that waste product of carbon dioxide away, so it's going to drain into the coronary sinus, which is towards the back of the heart, and this is known as also a vascular sinus. They have very thin walls with no smooth muscle, and it's going to ultimately drain into the right atria of the heart. So coronary circulation is really important because if any part of this circulation to the heart muscle gets blocked, we can have some major heart problems and issues. Now, it can get blocked a number of ways. These blood vessels could be blocked by blood clots, where a blood clot forms inappropriately and it blocks an area in the heart. It could also be due to what we call fatty arteriosclerosis plaques. These are the ones you see in the pictures or the commercials where the yellow stuff starts building up in the artery and blood flow can't continue, like if for high cholesterol type commercials. It's a buildup of that. We can also see spasms of the coronary arteries can happen. So when they spasm and they constrict, this is going to constrict blood flow and reduce it to the heart muscle itself. Anytime the heart muscle gets constricted or low blood flow, this is called ischemia. This is because it's not getting oxygen. Now, if the heart is not getting oxygen for a certain amount of time, we might see one of 2 things happen. The first thing is what we call angina pectoris. This is severe pain in the area of the heart that has reduced blood supply. It's not a heart attack yet. However, it's kind of like your warning signal that, hey, something's happened and there's a blockage here where we're not getting enough oxygen. A lot of times this is going to happen when a person is exercising or exerting themselves where their heart rate increases. Once they relax and they sit down and they let their heart rate come down, the pain normally subsides and goes away. Okay, and we are notorious for this kind of thing where you're like, well, if it continues to hurt for 10 more minutes, I'll go to the ER, or I'll go to the doctor, I'll go get it checked out. But then they sit down and rest and it goes away, so they don't think about it. However, this is its warning sign that a heart attack is probably going to come eventually. Well, what is a heart attack? A heart attack is known as a myocardial infarction. Okay, when we look at a myocardial infarction, this means the blood supply has been blocked off for long enough that there's actually death of the tissues of the myocardium. Some of the muscle tissue dies due to the lack of oxygen. All right. Now, if this is due to a blood clot, we do have some medications like streptokinase that could be used if it's used quickly to dissolve the clot and hopefully to prevent permanent damage or at least limit the amount of damage to the heart itself. All right, and so that's what we're looking at. Also, a little later in this PowerPoint, we'll talk a little bit about like coronary artery disease, but also what we call a CABG when somebody goes in to have coronary bypass surgery. It means that there's blockages in these blood vessels in this coronary circulation, and they want to bypass the blockage so that the heart muscle can continue to receive nutrients and oxygen. So if you take a look at this picture, of course this picture is also found in your book. It's showing you coronary circulation. It is found on page 701. Over here on the left side, you're going to see that it's showing you mostly the arteries, okay? The ones that are kind of more opaque or lighter color, those are in the back, so they've kind of made the heart see-through so that you can kind of see that. Also see the veins that are going to run through over here on the right side, and the kind of sac-like structure that's in the back over there, that's the coronary sinus, where it's going to collect the blood and return it to the right atrium of the heart. Now, it's all well and good when we look at, okay, well, the heart's a pump. It's going to pump the blood from point A to point B, but how does it do this? How does it have the ability to pump and to continuously pump without you actively having to know that that's happening? I mean, think about it. We have a hard time finding our keys, our sunglasses. They even might be on our head. There was one time I was talking to my husband on my cell phone and I was telling him I could not find my cell phone. Well, I was using it, okay? And so there's times that we have a hard time multitasking. If we had to sit here and tell our heart to beat every second, we'd have a problem. So our heart has this area that's called the conduction system and pacemaker system. So cardiac tissue is a specialized tissue, and it has the ability to generate and conduct spontaneous action potentials. Okay, so you're not going to have to actively be thinking about these action potentials. This is going to stimulate cardio muscles to contract and push the blood the way they're supposed to. These cells are said to be what we call autorhythmic. Auto means self, rhythmic means they're going to have their own rhythm. So they're self-excitable. They go through the process of creating and pacing your heart on their own. This conduction system sets up the rhythm of your cardiac contractions. It sets up your heart rate, whatever that might be. The better shape you're in, the lower your heart rate normally is, because your muscle in your heart is more efficient at pumping the blood, so it doesn't have to do it as often. This is going to make the atria and the ventricles contract in their appropriate sequence, the way that they're supposed to. Now, when you look at this picture here, guys, this is showing you the cardiac muscle. You can see that it is striated. You can see that they're held together with these cross bridges and these intercalated discs. You can also see over here in the picture where the gap junctions are, so that they can communicate very quickly, so that they're all going to be excited and contract together. Now, these are going to be held together by a lot of different structures. One's called the desmosomes. Desmosomes are going to hold these different fibers of the heart together. We also see the intercalated discs. These are going to be attachments between the cardiac cells, the branches. And we also see the gap junctions, and the gap junctions allow for the muscle action potentials to be conducted from one fiber to the next very quickly. It's to allow for quick coordination of our contractions. So let's take a look at the components of this conduction system. Okay, the first component, the main player here that we're going to look at is called the sinoatrial node, or the SA node. This guy is known as the pacemaker. Okay, it's located in the wall of the right atria. It's just below the superior vena cava opening. The SA node is going to start each action potential. It's the one that's going to send the signal, and it's going to fire, and it's going to tell your heart that it's time to contract. And it's going to keep a rhythm or a pace. Okay, that's why it's called the pacemaker. Now, it actually sends a signal about 90 to 100 action potentials per minute. Each action potential spreads through both the atria, so it's going to spread through the atria first so that they contract first using those gap junctions and those intercalated discs, and both atria are going to contract. There is what we call a refractory period that happens though. Once those muscles have started their contraction process, they have to contract completely, and then they have to relax completely before they can listen to another signal to contract. Okay, this is called the refractory period. So even though the pacemaker is continually sending the signal, okay, it means that it's not necessarily going to hear every signal or contract with every signal, because we have to let the heart reset. So not all action potentials result in a contraction. Normal heart rate, resting heart rate, is about 75 beats per minute. Again, if you're in better shape, this can be lower. If you're in worse shape, it could be higher, right? But 75 is kind of the average, even though they're sending 90 to 100 signals every minute. Only 75 are getting through. Then the SA node is going to communicate with what we call the arterioventricular node. This is going to be a node that is going to be located right where the connection between the atria and the ventricles come in contact. Okay, it's located in what we call the interatrial septum. This is going to have where action potentials will also spread from the SA node here to the AV node, and these AV nodes are going to slow down this action potential. This slowing down allows for the atria to fully contract before the ventricles get the message that it's time for them to contract. So there's going to be a delay that provides a chance for the ventricles to be filled with blood, because the atria are emptying their blood into the ventricles. We then see that there's what we call the arterioventricular or AV bundles. This is going to be a bundle that runs down the ventricular septum. This is also known as the bundle of His. It runs from the AV node down the intraventricular septum, and this AV bundle is going to send the electrical conduction between the atria and the ventricles. Okay, so it's going to be that connection. Everywhere else, the connective tissue separates and electrically insulates the atria separate from the ventricles. So this is why those atrial fibers are going to all contract together, where those ventricle fibers are going to all contract together, because they're separated by special connective tissue. Now, this bundle is going to separate into a right and left branch. These right and left bundle branches are going to allow for the signal to continue to be traveled down the septum towards the apex of the heart. So if you remember, your heart is kind of a triangle shape. It's going to allow it to travel to the apex, to the point, okay? Once it reaches the point of the heart, it's going to hit these Purkinje fibers. Purkinje fibers are going to be fibers that come up the sides of the right and left ventricle. Okay, they're going to come up into the myocardium. This is going to allow for the action potential to move rapidly, because these are very large diameter fibers. The apex then is going to contract first, and it's going to push the blood up out of the ventricles, either to the pulmonary circulation or the systemic circulation. So when we're looking at the heart here, we're going to see that the signal is sent for it to beat. The atrium are going to contract first, and they're going to contract, pushing the blood down into the bottom part of the heart. Once they start relaxing, then the ventricles are going to contract from the bottom up. Okay, and so they're going to push the blood down. These guys are going to push the blood up, and it's going to be a back and forth that happens. Okay, and they're going to alternate between contraction and relaxation. Okay, so contraction, relaxation. So they're going to go back and forth in this process. So if we take a look at this particular picture, it's showing you the conduction system. This is a very important picture. It is located in your textbook on page 705. If you'll notice here, you have the SA node. It's going to send the signal, and you'll notice it goes to both the right and left atrium, allowing them to get ready to contract. It also sends a signal to the AV node. The AV node is going to slow down the signal until the atria have a chance to contract and push the blood into the ventricles. Then the signal is going to travel down the atrioventricular or AV bundles, or the bundle of His, which you can see here. It's going to branch into a right and left side, and then finally into the Purkinje fibers, and we are going to see a contraction from the apex up, pushing the blood out of the ventricles into the pulmonary circulation or into the systemic circulation, depending on which side of the heart we're looking at. Now, the timing of these atrial and ventricular contractions are super important. The action potential from the SA node to the AV node takes about 50 milliseconds. It's a very short time period. The muscle fibers in the AV node have smaller diameters, and so since they're smaller, it's going to take the signal a little longer to pass through these, so it slows down the signal. This 100 millisecond delay gives the atria time to contract and push the blood into the ventricles before the ventricles are allowed to contract. The ventricles are then going to contract at approximately 0.2 seconds or 200 milliseconds after the atria contract. So guys, it's actually pretty fast. Okay, so even when I'm showing you with my hands where I have the contraction, relax, and they're going back and forth like this, and it's a lot faster, okay, process with your heart, because it's going to take less than a second, even they're milliseconds, less than even half a second to get these jobs done. Now, signals from your autonomic nervous system and your hormones like epinephrine can modify your heart rate. Okay, they can actually increase the strength of the heart rate, the speed of the heart rate. They can increase the strength of the contraction of the muscle of the heart. And so because of this, they can alter your heart rate. So it's not always just sitting at, say, 75 beats per minute. So an example is acetylcholine. Acetylcholine is a neurotransmitter. This is going to be released from the parasympathetic nervous system, and it's actually going to slow down the SA node. This is going to be when your body's in that rest and digest, and so it's going to slow your heart rate. On the other hand, hormones like epi and norepinephrine get released from the sympathetic nervous system or from the adrenal medulla, the adrenal glands, and they will actually speed up the SA node to speed up your heart rate in a fight or flight type situation. Now, what happens if our SA node starts not working correctly? Let's say it gets damaged, or as we get older, it just stops firing like it should. Well, the AV node can take over. The problem is now the AV node is not getting the signal from the SA node. The AV node has to send the signal up to the atria and then also down to the ventricles. So this is going to take it a little bit longer. Now, because it takes it a little bit longer, the heart rate is going to be slower. Now, if the AV node gets damaged, then the AV bundle branches could take over the pacemaker function. But each time we move down into these structures, the heart rate gets slower and slower. So it can go from being normally 75 beats per minute down to 40 to 50 beats per minute, down to 20 to 40 beats per minute. Guys, if it's 40 beats per minute, that's not enough pressure to push the blood into your brain so that your brain's getting enough oxygen. So it's going to cause some major issues and ultimately death of the patient if it's not corrected. So how can we correct this process? Well, we can put in an artificial pacemaker. Okay, they can put a pacemaker in just right under the skin here, and the wires connect to the heart, and it helps keep the pace for the patient instead of the SA node. The SA node's not doing its job, so the pacemaker takes over, sending out those particular signals, okay, keeping the pace of the heart. A lot of times, guys, these artificial pacemakers are not just pacemakers anymore, they're also defibrillators. The defibrillator can also shock the heart if they show arrhythmias where the heart's not pumping like it should. So now let's talk about how the muscles in the heart actually do their contractions. How do they contract to push the blood through the body? So cardiac muscle fibers are what we call contractile fibers. They do have a resting membrane potential of about a -90. So if you'll recall back from the nervous system tissues, and we talked about the transduction of a signal down, or the action potential down a neuron, you'll know that there is this resting membrane potential that's there, and here it's at about -90 millivolts. When the action potential from the SA node gets sent out, it opens those voltage gated channels, which are going to allow for fast sodium to come into the cells. Now remember, sodium is a positive ion, so if we started at -90, that number is going to start going up towards 0. This sodium quickly moves into the muscle cells, causing rapid depolarization, and the fast sodium channels, though, quickly close. They don't stay open for a very long time, but it is long enough to allow for a very quick influx of sodium or positive ions. There's then going to be what we call a plateau phase. This phase is called a refractory period. This is where voltage gated channels that are a little slower, calcium channels, are going to open. This is going to be in the sarcoplasmic reticulum, that's what the SR stands for, and the sarcolemma. Sarcolemma, remember, is the plasma membrane of the muscle cell. The calcium increases in the intracellular fluid. So calcium moves into the cell from the extracellular fluid, and it also moves out of the sarcoplasmic reticulum, which is also known as the smooth ER. The calcium then binds to the troponin. This covers the myosin binding sites of the actin, and so it opens it up so that the actin and myosin can come in contact with those cross bridges, and they can pull and cause the power stroke. This whole idea of pulling and causing the power stroke is going to cause the muscles to overlap, those fibers, the thin and the thick fibers, to overlap, and the heart contracts, the muscle contracts. You can recall this back from the muscle tissue chapter from Anatomy 1. Now, membrane potentials are going to remain steady for about 250 milliseconds. This holds the depolarization. The sodiums cannot be moving in, but calciums are going to have the ability to be moving into the cell. Remember that in a neuron or skeletal muscle, depolarization lasts about only 1 millisecond. It doesn't last for very long. However, in cardiac muscle, there is an area or a time called the refractory period. This lasts about 250 milliseconds. It's longer than the contraction itself. The contraction of the muscle is about 200 milliseconds. The whole point that this refractory period, or this relaxing period where it cannot receive another signal, is longer, this actually helps protect the heart against what we call tetany. Okay, tetany is where that it spasms and it contracts like a Charlie horse and it won't relax. Okay, so it helps prevent you from getting that whole idea of a Charlie horse or muscle cramp in your heart. Okay, because we know how painful it is in our calf or in the instep of our foot, where it causes your toes to go all crazy and you can't walk and then it's sore. We don't need our heart to do this. So the heart has the ability to have this refractory period, which helps protect it from getting a actual kind of spasm for the most part. Now, after this whole refractory period, we see that there's going to be repolarization. So after the refractory period, those voltage-gated channels are going to open that are for potassium. The potassium is then going to leak out pretty quickly into the extracellular fluid. This is going to bring us back from our positive number back towards our negative 90 so that we can reset for the next contraction. At the same time, the calcium channels close, fewer calciums are moving into the cell, and the membrane potential becomes more negative again, and we're repolarizing so that we can receive another signal to allow for another contraction. Now, epinephrine, guys, causes more calcium channels to open during that plateau phase. So this actually causes the contractions of your heart to be stronger. Okay, that's what epinephrine can do. Calcium channel blockers actually cause fewer calcium channels to open, and this will actually decrease the strength of the contractions. This can be a big deal. Let's just say if you have high blood pressure, the harder the contraction, the more pressure that's going to be behind the blood. And so they may use a calcium channel blocker to help manage your high blood pressure if there's a potential issue. Now, in your textbook, it shows you what is happening in each of these phases that the muscles are going through, where they're going to depolarize, where they're going to contract in their plateau, where they're going to have a repolarization, or what we call the refractory period. This picture is found on page 706 in your book. So if you look here at number 1, you have a rapid depolarization due to an influx very quickly of sodium ions. This is then going to enter into the plateau phase, which is number 2, where we're going to see a lot of calcium come into play. This calcium is going to help remove the markers so that the actin and myosin can come together and a contraction can actually take place. And then we also see that we're going to see that some of our potassium channels are going to start opening, and repolarization is going to occur in step number 3. Now, we cannot do a contraction of the heart again until we get back down to that negative 90, which you can see it gets back down here in the chart, and then the next contraction can take place. So guys, even though we're looking at the fact that it depolarizes, it plateaus, and it repolarizes, this whole process, if you look down here at the bottom, takes about 0.3 seconds. So it's actually a very quick process. Alright, so when this process is happening where we're seeing contractions of the atria and the ventricles, we can actually read this on what we call an electrocardiogram. Because the heart is running on electricity, we can actually detect it, and it gives us a picture. That's what the gram means at the end of this. So the electrocardiogram. We abbreviate this a lot of time as an EKG or an ECG. It's a recording of the electrical changes that are accompanying that whole idea of the cardiac cycle and the heart actually doing its contractions. So when we are looking at a normal EKG, you are going to see 3 main kind of structures. The first structure you're going to see is what we call the P wave. The P wave is where the atria are doing their depolarization. So the SA node is going to fire. It's going to allow the atria to contract. So if the P wave gets enlarged, like it's too big, it may indicate that the atria of the heart are also enlarged because it took longer to send the signal and allow them to contract. We then see you're going to have what we call a QRS complex. The QRS complex is when the ventricular chambers are going to do their depolarization, and they're going to do their contraction. Now recall, as they're doing their contraction, the atria is starting to relax, okay? So after the P wave, after they've contracted, they're going to start relaxing. Now if the Q wave is enlarged, we're going to see that that could be a possible myocardial infarction. If an R wave is enlarged, it could be a possibility that the ventricles are enlarged. The EKG can actually give us a really good idea of what's going on in the heart. This is why in a heart hospital, the patients are all hooked up to the EKGs all the time, and there are nurses that sit there and watch them. If you want to specialize in cardiology and be a cardiology nurse or something like that, you're going to have to learn how to read EKGs, and you're going to have to be able to see if these waves are becoming too long or too short to see if there are potential issues. The last wave we're going to see is what we call the T wave. The T wave is where the ventricles are going to repolarize and they're going to relax. This is going to allow then for another P wave to take place so that we can have another contraction of the heart. If the T wave is flattened, this normally means that there's not enough oxygen getting to the cardiac muscle. Okay, so resetting is kind of a harder deal, because remember when we talk about how muscles contract, they not only need ATP to pull, they also need ATP to relax. Okay, so it's really important that the oxygen is there to help create the ATP. If the T wave is elevated, it could be an indication that there is a high potassium level in the blood, and we call this hypercalcemia. So this shows you right here a regular electrocardiograph, okay, an EKG that's recorded. So you can see the P wave. In the P wave, this is where the atria are doing their contraction. Then you can see the QRS complex. In the QRS complex, that's where the ventricles are doing their contraction. And they're going to contract for a longer period of time because they're larger and they're pushing the blood into areas that are further away. Then you see the T wave, and the T wave is going to be when they relax. And then we're going to have a small space before the next heartbeat will take place. All right, so this is what a normal EKG would look like. So when we take a look at our normal EKG, we saw that there is a section between the P and the Q. This is going to be called the PR interval. This is the time from the beginning of the atrial excitation, where the atria get excited, to the beginning of when the ventricles get excited. So the beginning of the P wave to the beginning of the QRX complex. If you have a longer PQ interval, it could be due to myocardial damage. That's something that could have happened. You might have had previous heart attacks or scarring of the heart or something like that. If we look at the ST segment, this is what we call the plateau phase. This is when the ventricles are fully depolarized, the end of the S wave to the beginning of the T wave. This segment, if it's elevated above the baseline, okay, because if you look in the picture over here, you have the baseline that's causing it to be at the base. If this is elevated above the baseline, that could be potential myocardial infarction. The ST segment, if it's depressed below the baseline, it's telling you that there's insufficient oxygen going to the heart itself. If there's an issue from the QT interval, this is going to be the interval that begins with the QRS complex to the end of the T. If we have a longer QT interval, this is normally due to myocardial damage or ischemia, where there's reduced blood flow. This could be where it's letting us know that there's a potential blockage that's taking place. The blockage may not be 100%, but it could be getting to that point that could potentially cause problems for a heart attack or myocardial infarction. So guys, in your textbook, you have an action potential propagation chart through the heart. This is found on page 709, and on page 708, it actually has each of these numbered, and it describes what is happening in each of these phases. You'll see that it shows the heart, and it also shows what's happening on the EKG. So when we look at this with number 1, you see depolarization of the atrial contractile fibers. This is going to help produce the P wave, so you can see that in number 1. In number 2, you have the atrial systole, which is the contraction that takes place. They're pushing the blood out of the atrium into the ventricles. Then you see the depolarization of the ventricles so that they're ready to do their contraction with the QRS. Then you'll see a flat line there where they're actually contracting and pushing the blood out. When we have the T wave come up in number 5, this is where we are going to reset the ventricles. They're going through the process of going to They're going through the process of repolarization. Then you see we have what we call ventricular diastole, which is the relaxation. At this point, guys, both areas of the heart, the atria and the ventricles, are relaxed, but the atrium are getting ready to start the next cycle, which is going to give you the next P wave and so on. So this is just giving you kind of a rundown, and again, this is found on page 708 and 709 in your book. So this brings us to some terms that we need to know. Systole is going to be the word we use for contraction. Diastole is, or dystole is the term for relaxation. So when we look at the cardiac cycle, a single heartbeat, you're going to see that there's going to be systole of the atria. Okay, that's the contraction of the atria, occurs simultaneously at the same time as the dystole of the ventricles. So when the atria are contracted, the ventricles are relaxed. Now, dystole of the atria is going to occur simultaneously with systole of the ventricles. So when the atria are relaxed, the ventricles are going to be contracting. So there's opposite that's happening here. So we see the systole of the atria where the ventricles are relaxed and they are in dystole. Then we see that the atria goes into dystole and we see the systole of the ventricles. And this is going to go back and forth, okay, that we see happening here. Now, when we talk about systole and dystole, we are looking mostly at blood pressure. Blood pressure is usually measured in a larger conducting artery. Normally, it's going to be on the left side, and it's going to be your brachial artery right here on the left side. This is why they put the blood pressure cuff right here. Blood pressure is going to be measured there because it's going to have the higher pressure. It's going to give you the pulsations that you need to be able to detect the blood pressure. Systolic blood pressure is the higher number. It's going to be the higher pressure measured during the left ventricular systole. So when the left side of the ventricle is going to contract, that's what we're detecting there with that higher number. The dystolic blood pressure is the lower pressure measured during the left ventricle when it's in dystole or relaxation, okay, and this is when the valve is closed, okay. It's never zero because there's still pressure that's coming behind it. However, we are going to see it's the lower number. So the systolic blood pressure is the higher number we normally put on top. The diastolic is the bottom number. Now, normal blood pressure is going to vary by age, okay? So it's going to depend on age and even depending on sex, whether you're male or female. But it is approximately 120 over 80, okay? This is 120 millimeters of mercury, the systolic pressure, over 80 millimeters of mercury, which is the diastolic, in a young, healthy adult. In females, the pressure, because their bodies are a little smaller, they have less blood to push through, 8 to 10 millimeters of mercury less. All right, so that would be more of like a 110 over 70. Now, people who have really good physical or in really good physical condition, like they're athletes, their blood pressure normally will be lower. Or if you just have really favorable genetic predisposition, you may have lower blood pressure as well. Whereas others of us, we are predisposed to having higher blood pressure due to family history. So when we look at the cardiac cycle, guys, it's important to see that there is a relaxation period. This is immediately after a heartbeat or the end of the T wave. All 4 chambers of the heart are in dystole or relaxed. The pressure is low in the atria and the ventricles because of them being relaxed. The SA valves, the pulmonary and aortic valves, are going to close. The whole point of them closing is to prevent the backflow of blood back into the ventricles. Then we're going to see that we want to fill the ventricles up. In order to fill the ventricles up with blood, the ventricles are going to have to be relaxed and the atria are going to go through their contraction phase. This is where the AV valves will open, the tricuspid and the bicuspid, they'll open, and blood is going to move from the atria to the ventricles. The ventricles begin to fill with blood, increasing their volume, and this is going to cause them to stretch. The SA node fires, the atria depolarize, this is the P wave, and their contraction takes place, and we call that atrial systole. Then, once we see that the blood has emptied out of the atria, we want to then get the ventricles ready to contract to push the blood either to the lungs or the rest of the body. This is the QRS complex on our EKG, where the ventricles are going to depolarize, and the ventricles are going to go through the process of contracting. The ventricular pressure is going to increase. This is going to close the AV valves. The SA valves, the SL valves are going to still be closed here as well. The SA valves then will open when the ventricles do their contraction so that they can empty the blood out of those chambers. Now, this whole process of moving blood through the heart and this opening and closing of valves actually creates sounds that we can hear in our heart. The first sound is called the S1 sound, the sound 1, and this is the lub sound. This is the closing of the AV valves at the end of ventricular filling. So you'll hear the blood turbulence against the AV valves. So as the ventricles get ready to contract, the turbulence of the blood, the waves of the blood will hit this closed valve, and that's what you hear as the sound, and that's the lub sound. The second heart sound is the dub sound. This is the closing of the SL valves. This is the beginning of the ventricular dystole, or the relaxation of the ventricles. Okay, so that's the dub. And so that's why a lot of times when you hear a heartbeat, it kind of sounds like lub dub, lub dub, lub dub. You're actually hearing the turbulence of the blood against these closed valves. There is also an S3 and S4 sound, but they can only be heard with special equipment. They cannot just be heard with the spirometer. They can't just be heard with just your basic equipment. However, if these valves do not close properly, we see that heart murmurs can occur. This is an abnormal sound in the cardiac cycle. This may mean that something's wrong with the valve where they're not closing properly. We can call this mitral valve prolapse, or MVP. It could have been due to rheumatic fever where it attacked the valves where they can't close. And then their heart's going to sound a little bit different. You're not going to necessarily hear the lub dub as well. You're going to hear some backflow of that blood because those valves are not closing. I have a double heart murmur, and so you can actually hear that there's a big difference. And a lot of times when they listen, it's like the whoosh, the whoosh, the whoosh, because the blood is flowing backwards where it shouldn't. If this continues, which it will, the valves will start to wear out more and more. Well, valve replacement will have to take place in order for my heart to function properly, because we don't like that backflow of the blood. It makes the heart less efficient. So in this particular picture of the cardiac cycle, it is found in your book on page 711. It kind of takes everything we've talked about and it puts it together in one place. At the very top, it shows you the EKG with your P, QRS, and T wave. In part B, it shows you the pressures, how much pressure is in each of these structures at any given time during the P, QRS, and T. In C, you can see the heart sounds. If you'll notice, S1 and S2 are larger. Those are the ones you can hear, whereas S3 and S4 are a lot smaller and you cannot hear them. You also can see in D what the volume of the blood in the ventricles is happening when the volume is high versus when the volume is low. And then at the very bottom, it shows you the phase of the cardiac cycle, what's happening actually in the heart and where the blood is moving. So this kind of takes everything we've talked about and puts it in one diagram, and it is found in your book on page 711. All right, so the next thing I want to look at is what we call cardiac output, or CO. This is the amount of blood that gets ejected from the left ventricle into the aorta per minute. When we want to calculate the cardiac output, we have to look at two things. We have to look at the SV, which is the stroke volume, and the HR, which is the heart rate. All right, so we take the stroke volume, which is the amount of blood ejected by one ventricle during one systole, during one contraction, and then we're going to multiply that by the heart rate, because the heart rate is going to tell you how many times it contracted each minute. So when we look at the stroke volume, it's going to depend on a couple of variables, and they are put into this kind of law of the heart. We don't actually see a lot of laws in biology. You see a lot of laws in physics and things like that, but there is a law in biology which is called the Frank-Stalling law of the heart. The Frank-Stalling law of the heart says the greater the cardiac muscle fibers are stretched, so the more blood that comes in and stretches the fibers just before they contract, the more forcefully they will contract and push the blood forward. This is a harder contraction, which means it'll increase the stroke volume. So more blood actually is going to be put out, and that's that cardiac output. Okay, so it's that stretching. So it's kind of like if I was to... So this would be like if you were to take this hair tie, and if you just stretch it a little bit, there's not going to be much backlash with it. Okay, so there's not going to be much pain with it. But if you pull it harder and you let it go, it could hurt a lot more, especially if it's on like your wrist like this and you pull it up. The further you pull it up, the more it's stretched, the more it's going to have as it comes back down, the more force. That's what this Frank Starling law of the heart's talking about. The more blood we put in there that fills and stretches the ventricle, the more strength it's going to have when it recoils and pushes the blood out. And so this can increase the stroke volume, which will increase the cardiac output, how much blood is leaving the heart. When we look at cardiac output, there's a lot of factors that come into play. This particular diagram is showing you how the stroke volume can affect cardiac output, and it also shows you how heart rate can affect cardiac output. This picture is found on page 716 in your book. So when you're looking at this, guys, it's just showing you that if you have an increased preload, like more coming in, or you have an increased contractibility where it's being told to contract harder, or a decreased afterload, there's not a lot of blood that's left over, all those things can increase the stroke volume, which will ultimately increase the cardiac output. On the other hand, if the heart rate gets increased, either due to the nervous system, certain chemicals, or other factors, just based on the fact that of your age, your sex, your physical fitness, that can also affect your cardiac output. So when we look at these two things, it's really important to understand, because they're in a multiplication type problem, like you can see here, we're multiplying SV times RH, that if either one of those changes, it's going to ultimately change the cardiac output. Okay, that's what this chart is showing you. All right, so now we're going to talk a little bit about some of the disorders that deal with the heart. Some of these may sound very familiar to you. Others may not. I hope most of them probably sound pretty familiar to you. But one of them we want to talk about is the congestive heart failure. Congestive heart failure is when the heart cannot supply the body with enough oxygen. This is because the pump, the heart, which is the pump, is failing. Okay? And a lot of times this can be caused by chronic hypertension, where you have chronic high blood pressure. It could be due to heart attacks, myocardial infarctions. It could be due to a number of things. So with congestive heart failure, we get decreased blood flow to your body tissues because it's not pumping the blood as well. Cardiac output is being decreased. So we see that what happens here is, since we're not forcefully pushing the blood like we should, blood's going to start accumulating in certain organs, okay? Because the heart can't pump the blood out of those organs and back to itself, or out of the lungs and to the lungs to pick up oxygen, and then out of the lungs. So we actually see that there's going to be some swelling or edema that's going to take place. Edema is excessive fluid in your tissues where the blood could be sitting there for too long because the pump is not pushing or pulling as quickly as it should. So if the left side of your heart starts to fail, okay, so the left side of the heart starts to fail, you're actually going to start to see pulmonary edema. You're going to start seeing that the fluid's going to build up in their lungs. And you're like, well, wait a minute, that's what's supposed to be filling the left side. The problem is the left side is the systemic side, and it should be pushing the blood through so that it goes back to the right side so that they can push it to the lungs. They're not doing that, and so then the fluid is sitting in the lungs for too long and causing edema. So we see the right ventricle still pumping blood into the lungs, but the lungs are not emptying like they should. Now, if the right side of the heart is the problem, it's failing first, you're going to have peripheral edema. You're going to have edema in your systemic or your peripheral type organs, your arms, your legs, that sort of thing. This is where the left ventricle is still pumping the blood it receives to the tissues, but the tissues aren't emptying because it's not pushing it and pulling it back up into the right side of the heart. So we see that there's that issue. So this is what we look at for congestive heart failure. Is there fluid building up in their extremities and their systemic organs, or is there fluid building up in their lungs? This can let us know which side of the heart is weaker at this point. Now, before I get back to some of the disorders, let's go to look at what heart rate is. Heart rate is your beats per minute. That's what BPM stands for. Adjusting your heart rate is a major mechanism for adjusting cardiac output and also your blood pressure. Your heart rate depends on several variables. The first thing is just the nervous system control. Remember that the cardiovascular center, that's a reflex center, is found in the medulla of your brain. There's going to be barioreceptors that detect stretch in the aortic arch, or that detect stretch in the aortic arch that comes off the heart, and also the carotid arteries here as it comes up to the brain. These two areas are going to constantly be telling the medulla whether or not enough oxygen is going to be sent to the brain due to blood flow. In the sympathetic nervous system, if we need to, it's going to increase the heart rate and force the contractions to be stronger. However, in your rest and digest phase, the impulses are going to decrease your heart rate. Heart rate also is going to depend on a number of hormones. Epinephrine, norepinephrine, T3, and T4 are all going to raise your heart rate. One reason for this is epinephrine and norepinephrine are part of that fight or flight or sympathetic response. T3 and T4 are to increase metabolism. Well, if we increase metabolism, we need more oxygen, we need more nutrients, which means the blood has to deliver it more, so it's going to increase the heart rate. We also see some ions that are going to play a role in heart rate, like sodium, potassium, calcium, and these all have to do with that whole idea of those action potentials. Okay, so remember, we have sodium channels open and sodium has to run in. We also have calcium that's got to come in. We have the potassium that has to leave to reset the heart muscles. So if any of these are out of whack, it can ultimately affect the heart rate. So it shows you here, like if sodium and potassium are an issue, we can have a lower heart rate. If calcium is higher, we can have a higher heart rate. And so when we're looking at this, some of these ions can play a role. Heart rate is also going to depend on some other things like age. Your heart rate is going to decrease with age. And we actually do see this, that when you look at children or even babies before they're born, their heart rate is very high. It's in like the 160s and things like that. It should decrease the older you get. And that's why when we look at extremely old people, their heart rate is very low, they feel cold, their skin is pale. That's because their heart's not pumping the blood to these areas like it should. Gender can also affect the heart rate. Females normally have a slightly higher heart rate than males. Physical fitness, if you are in more physical shape, like very athletic, you tend to have a lower resting heart rate. Body temperature, low body temperature is associated with a lower heart rate, and the list can go on and on. So there's a lot of things that can affect heart rate. Now, one thing we did see here though is that the nervous system does affect the heart rate, and this is that autonomic nervous system, and it is located in the medulla. So if you look here, it's showing you the medulla, which is the cardiovascular center, which is a vital center and it's part of the brain stem. It shows you that you're going to get input from the cardiovascular center, either from higher brain regions like your cerebral cortex, your limbic system, your hypothalamus. Let's just say you get scared by something, or it's dark and spooky in your house and you're like nervous about going in. This can ultimately affect your heart rate. Also sensory receptors like your different chemicals like those ions we talked about, or the baroreceptors for blood pressure, they can also communicate to this area. How this area responds depends on if you need to go into a more fight or flight situation where the sympathetic is going to raise your heart rate, whereas if it's going to need to be more in a rest and digest, like you need to calm down, that's where the vagus nerve is going to be part of the parasympathetic, and it's going to slow your heart rate. So this is just showing you how your autonomic nervous system innervates your heart. All right, so back to some disorders. These are talked about at the end of your chapter, in this chapter. One thing you need to make sure that you do is you need to read about these different disorders at the end of the heart chapter, because this is what you're going to see a lot in hospitals. They start on page 720 and they continue through page 726. Also, you're going to see ones that we're not going to talk about here is when you can see issues on the EKG. There's some abnormal EKGs also located in the section, so you should take a look at it. So the first thing we look at here is heart disease. This is called coronary artery disease. Coronary artery disease is also abbreviated as CAD. It's an area of partial or complete blockage of coronary circulation to a certain area of the heart. If this happens, cardiac muscle cells are going to start to die because they need a constant supply of oxygen and nutrients. So if there's a reduction of this blood flow, those heart muscles are not going to be able to perform as well as they could if they were getting the supplies they need. This is called coronary ischemia, and it results from partial or the complete blockage. A usual cause is the formation of fatty deposits that happen here. That's that plaque we talked about that can build up in the wall. The plaques could also be affected by a thrombosis or a clot because the passage has been narrowed by the plaque, so the thrombosis or clot gets caught. We also see there could be a spasm of the smooth muscle where the vessel walls will contract, decreasing blood flow, and one of the first symptoms of coronary artery disease is commonly known as that angina pectoris, which we talked about earlier. So with angina pectoris, it is the most common form. It's a temporary ischemia that develops when the workload of the heart increases. So during physical activity, it could be like mowing the lawn or exercising or something like that. Although the individual may feel comfortable when they sit down and rest, if they go through an exertion phase where they exercise or do something that takes a toll on their body, or they go through emotional stress, it can actually cause pressure in the chest, their chest to start to constrict, pain that will radiate just like a heart attack. But it's not a heart attack yet. It's just mimicking the heart attack, but it's letting you know that that heart attack is probably going to come if you do not get some treatment. Well, what is the heart attack? The heart attack is known as the myocardial infarction, or an MI. This is a part of the coronary circulation becomes blocked and the cardiac muscle will die from the lack of oxygen. The death of the affected tissue creates a non-functional area. That's what an infarct means. It's a non-functional area of the heart. Heart attacks most commonly result from severe coronary artery disease because the blockage has continued over time, causing it to no longer be able to be serviced and have blood delivered. If it occurs near the start of one of the coronary arteries, the damage could be very widespread on the heart. If the blockage is in a smaller arterial branch, the person could potentially survive, but it is still an immediate crisis and complications could come into play. It needs to be looked at. Now, a crisis for an MI or heart attack often develops as a result of a thrombosis formation at a plaque, and this condition is called a coronary thrombosis. A vessel already that's been narrowed by the plaque can be blocked very suddenly, either by a spasm or by a very small blood clot that normally wouldn't cause a problem. So it's actually a combination of kind of everything that we're talking about there. Individuals having an MI experience will experience intense pain, similar to what was felt in angina, but it will persist even when they go to rest. Okay, with angina, we saw that it went away after they calmed down and they rested. With a heart attack, this does not happen. A lot of times people will say when they're having the heart attack, they feel like there's a lot of pressure on their chest, like somebody's sitting on their chest. We'll also see the pain may radiate down the left arm. That's referred pain, or also in the back, especially in women. They'll start to have pain in their back. What's kind of scary about this is that pain does not always accompany the heart attack. We want to think that it's going to cause a lot of pain and that sort of thing, but sometimes people are having heart attacks and they do not even realize that they are because they don't feel that pain. And this could a lot of times could be due to their perception of pain. Remember we talked about in the sensation chapter that some people have very high pain tolerances, where they may feel like a discomfort, or they just don't feel it at all, where it's not really an issue. If it's undiagnosed though, and the pain never becomes a problem, they could end up ultimately dying from a fatal MI because it hasn't been treated. A myocardial infarction can usually be diagnosed with an EKG and also blood studies. So they'll hook you up to an EKG to look at it. They also will do blood studies, because if you've had a heart attack, okay, those myocardial cells that have been damaged due to the fact that they haven't gotten oxygen, they actually start to release enzymes into your blood. These enzymes can be detected with a blood test, and some of these enzymes are things like cardiac troponin T, cardiac troponin I, and also a special form of creatine phosphokinase that they term as CKMB. And these can be seen where they'll say, oh, your cardiac enzymes are high in your blood. That tells you that you potentially had a heart attack because they were high. The cells were damaged. Treatment of coronary artery disease or myocardial infarction, when we look at this, about 25% of MI patients die before obtaining medical assistance. This is normally due to the fact that they have a fatal heart attack and they nothing can be done. By the time medical assistants or EMTs reach them, there's nothing that can be done. 65% of MI deaths among those under age 50 occur within an hour after the initial infarction. So it's really important to get help immediately if you suspect you're having a heart attack. Risk factors that can be modified to help prevent heart attacks and coronary artery disease is to stop smoking, high blood pressure treatment. So if you have been diagnosed with high blood pressure, having treatment to reduce that blood pressure is super important. Dietary modifications to lower cholesterol and promote weight loss is important. Stress reduction, it's easier said than done, but if we can reduce the stress, that's important. And also increase physical activity where appropriate. Okay, because if somebody has just recently had a heart attack, they have to be careful about how quickly they get into certain kinds of physical activity, because we don't want to put too much stress on the heart if it's already been damaged. But if you will exercise the heart, it's just like any other muscle. It can be strengthened. It's just with doctors' help and orders, that's how this needs to be done. Now, we also see that there's drug treatment for coronary artery disease. We can reduce coagulation, the risk of thrombosis, when a patient may take aspirin or Coumadin. This is why you'll hear about sometimes as older people, as people get older, they're told to take a little baby aspirin each day. That's the purpose. We can actually block the sympathetic stimulation, where we don't go into that fight or flight where the heart rate increases greatly. So there's some medication for that. We can also cause vasodilation. The dilation, and because remember spasms can end up causing us to have issues, we can dilate them. This is nitroglycerin can do this. You've heard about if they've been put on a nitro drip, that's what they're talking about. We can block calcium movement into the cardiac and vascular smooth muscle cells. These are calcium channel blockers because if you'll recall, calcium channels, if you have more calcium coming in, the contraction is harder. So with the contraction being harder, it's going to end up raising the blood pressure. In a myocardial infarction, drugs can be given to relieve pain. We can also see fibrinolytic agents to help dissolve clots, and they'll also give the patient oxygen to help supply more oxygen, because guys, the air we breathe is only about 21% oxygen, and so when they hook you up to oxygen, that's 100% oxygen. It makes your blood pick it up a little easier. If the myocardial infarction or the blockage that's there is more extensive, medication can't necessarily help. There's some non-invasive surgical ways that we can help take care of this. The first one's what we call an arthroectomy. This is where the blockage, it's normally by a single soft plaque. It can be reduced with the aid of a long slender catheter. This is used and inserted in the coronary artery to the plaque, and it dissolves the plaque. And this a lot of times is going to be a plaque though that's soft, not one that's harder. One that's a little more invasive is the balloon angioplasty. This is where the tip of the catheter contains an inflated or a small balloon, and when they go into the position of the artery, they inflate the balloon, okay, pressing the plaque against the vessel wall so it pushes it. It doesn't get rid of it, but it pushes it so it widens the vessel. And then a lot of times they end up having to put in a little insert. It's like wire mesh that they call a stent. The stent helps hold the vessel open, okay, and so this one is a little more invasive because they have to do multiple steps, but it's not as invasive as, of course, open heart surgery. However, there are cases where open heart surgery is needed. This is where you're going to have what we call a coronary artery bypass surgery or a CABG done. In a coronary artery bypass, they're going to take a graft. They're going to take a small section of a vessel. They're going to remove it from like a peripheral artery or vein that's kind of smaller away somewhere else in the body, and they're going to create a detour. They're going to graft it into the heart and detour the area that has the obstruction. So it's kind of like a detour when on a road they're doing construction work and they detour you down other roads to where you can finally get where you're going. It just might have taken you a little longer to get there. That's what's happening here. There's a blockage and they have to be detoured around. As many as 4 coronary arteries can be rerouted in a single operation. However, the top I've ever heard of is 5, but that's really pushing it. 4 is normally the max they want to do, and this is called a quadruple bypass surgery. So a lot of times the name is given based on how many of these they're planning on doing. The procedures are named based on that, where you have a single, double, triple, or quadruple coronary bypass. So if you look over here in this picture, you see a normal heart. You'll see that it's kind of lit up. The blood's flowing through there. It's getting oxygen and everything it needs. Over here on this other picture, you'll notice that there's blockages that are taking place where blood's not flowing, and you'll see a lot more black areas where that's going to be tissue not receiving oxygen or nutrients, and it's starting to die. All right, so we need to bypass wherever these blockages are happening in order to regain blood supply to them. Otherwise, the damage will be permanent and we can't bring the heart muscles back. So we talked a little bit about when we have the conducting system and an abnormal pacemaker function. When your heart rate gets too slow, it's abnormally slow, we call that bradycardia. If it gets too fast, it's called tachycardia. You can also have what we call ectopic pacemakers. These are abnormal cells. They generate a high rate of action potentials. They bypass your normal conducting system and they disrupt ventricular contractions. And so a lot of times what happens here is they'll have to go in and do what we call an ablation. They go in and they actually kill those cells. Okay, they ablaze those cells and then they put in the pacemaker to help control that better. Okay, because the other is so erratic, they want to get rid of it so that way they have more control of how the heart is going to have its pace. So this is what we're looking at when we're looking at the conducting system. All right, guys, so this covers chapter 20. So I hope this helps you kind of understand the heart a little bit more. One great thing is that you're doing a heart dissection, which allows you to be able to see these structures a little bit more up closely, seeing like how the difference of the muscle in the atria versus the ventricles, those chordae tendiae, those types of things. You can actually take a really good look at those when you do your heart dissections. If you have any questions or concerns, please feel free to contact me.